Well, thanks guys for joining us. My name's Adam Layton. I'm an assistant professor of emergency medicine and anesthesia and critical care medicine at Johns Hopkins University. I did my training in emergency medicine and then did a critical care fellowship. So I spend most of my clinical time in the ICU space now, but I'm definitely an emergency medicine at heart. I'm thrilled to have joining me today my esteemed friend, colleague, collaborator, Dr. Munbal Sultan, St. Paul Hospital Millennium Medical College in Addis Ababa, Ethiopia. Dr. Munbal is also an emergency physician and intensivist. He is the past president of the Ethiopian Society for Emergency Professionals, the ICU director and ICU fellowship director, critical care fellowship director at St. Paul, vice president of AFEM. His accolades go on, and I'm always humbled to get to share the stage with him. So I'm very happy that he was able to join us today and to talk a little bit about improving healthcare outcomes in resource-limited settings using clinical research, registries, and QI, and to discuss a couple of projects that he's worked on and that we've worked on together as part of that discussion. So I'll start off with a little bit of sort of conceptual background stuff, and then we'll talk about a couple of examples. I think that conversations about quality, value, patient safety have been central to discussions about medicine really for probably all of our careers, starting with Ta'ara's Human, the Institute of Medicine report that came out in 2000 that, I think really nicely summed up the problem is not bad people in healthcare, it's that good people are working in bad systems that need to be made safer. And I think that really changed how we thought about service delivery in the United States. I think it's taken some time for that idea to make it into the global health realm also. But that's quickly catching up, and I think is really changing how we're thinking about not just building new systems, but building high quality systems. So when we think about value in healthcare, we're really looking at the quality of care that you're getting compared to the cost that you're putting into it. It's easy to pour a lot of money into global health projects and not actually impact healthcare outcomes. And that's a poor value. It gets done all the time, but I think that we're moving away from saying we should spend this many millions or billions of dollars on this process and really looking at how we're moving the needle for the patient population that we're working with. The other sort of classic image in the public health space that we think about is the iron triangle of quality, access, and cost, where it's really hard to improve quality of care and improve access to care while containing cost. It's very easy to increase cost and not actually change quality, or to increase access, but have a lot of people providing low level of care that's not actually having a meaningful impact on healthcare outcomes. So with that background, we're going to talk about a little bit the burden of emergency and critical illness in low and middle income countries, talk about common challenges to quality improvement and capacity building in LMIC, EDs, and ICUs, and then to talk about the role of clinical registries and clinical research for describing the burden of disease, identifying opportunities for QI and capacity building, and then evaluating the impact of those efforts. So I talked a little bit about the focus on quality improvement and patient safety in the US. I think really sort of the parallel landmark moment for the global health space was 2018 with the Lancet Global Health Commission on high quality health systems in the Sustainable Development Goal era. And so this was a report that was published in Lancet Global Health over 5 years ago now. They made a couple of key observations that I don't think should sound particularly controversial to any of us, but I think really summed up nicely a gap in how global health was being approached up until then, or was being talked about. So they said there's a need for high quality context specific healthcare systems that can respond to changing population needs. Quality should not be limited to the purview of the elite or a distant aspiration. And poor quality care is common across conditions in countries with the most vulnerable populations faring the worst. And so really new research is crucial for the transformation of low quality health systems into high quality ones. So again, this is not a problem of bad doctors or bad people providing bad care. This is good people in systems that were not optimized to provide high quality care, providing the outcomes that their systems allow them to accomplish. I think the other important thing, and you are talking to two intensivists here today, and so I think we definitely see the world through the EM critical care lens, but I think that the professional divisions between emergency medicine and critical care that we have in the US are really in a lot of ways pretty arbitrary. And I think it's been really interesting to see how emergency medicine has developed in low and middle income countries and in sub-Saharan Africa in particular. Has really pushed and stretched those boundaries. So we can talk a little bit about how the field of emergency medicine and critical care as one field has really developed in Ethiopia, where the entire healthcare system functions a little bit differently. But I think in general, emergency medicine and critical illness really function as a spectrum. We know that there's a large and adequately addressed burden of emergency medicine and critical illness in LMICs, but the data limitations make it hard to describe the true burden, and that while it is possible to provide clinically and cost-effective care, it needs to be context appropriate. So understanding that the demographics, the epidemiology, the resource availability, the entire healthcare system really is different in those settings, and just trying to replicate what we do in high-income settings is not going to provide effective care, or not going to provide high value care, really. And so to address that challenge, accurate clinical data are essential for context appropriate capacity building in QI. When we think about emergency medicine disease, really these are conditions where interventions within minutes or hours are required to improve outcomes. And a very similar sort of a definition of critical illness, patients that have or are at risk of developing acute life-threatening organ dysfunction. This was a definition from the World Federation of Intensive and Critical Care that really stressed that the resuscitation of a critically ill patient is more about preventing further physiologic deterioration or worsening organ failure, and not about, oh, this patient has malaria, they need these specific drugs, or this patient has TB, they need these specific drugs. If somebody's in the act of decompensating, developing organ failure, dying, then we really need to stabilize and resuscitate them in a more syndromic way. This, I don't know how well that image comes across, but was a nice little diagram from one of the papers talking about the continuum of emergency medicine and critical care, showing that we're not talking about one specific disease condition. This isn't just infectious disease, malaria, HIV, TB, maternal conditions, trauma, stroke. This is really looking at the sort of common outcome of many different disease processes. And I think that's really where the overlap of emergency medicine and critical care excels, is finding those patients who are acutely deteriorating and stabilizing them, resuscitating them, and then allowing for more disease-specific treatments as they progress through their care. So I think this is sort of saying the same thing. It exists as a continuum. They're defined by a condition, not by a location or a phase of care. You see, certainly in many African hospitals where an emergency department has been developed and is very high functioning with expert staffing, there may not be the pre-hospital system or the in-hospital critical care systems that we are accustomed to in the US. And so, often that critical care continues to be provided for patients who stay in the emergency department for days or even weeks, where in our setting, those patients would be transitioned to a more sort of traditional inpatient ICU setting. And similarly, patients who are on a hospital ward can become critically ill as they decompensate, and that sort of rapid response or emergency response team can be filling a very emergency medicine sort of a role in rapidly recognizing, stabilizing, triaging patients who are experiencing a clinical deterioration. So again, just a little diagram showing that really to provide effective critical care and improve outcomes, you need to identify those patients, provide essential care to provide, and that's not just a individual doing a better job of their job. It's really about building the systems for hospital readiness and implementing the clinical practices that allow that care to reach those patients. I'm not going to spend a ton of time talking about global burden of disease, but we know that the burden of emergency medical diseases is 4 times higher in low-income countries than high-income countries, and that they contribute to more deaths and DALYs in low-income settings. There's a lot more diversity in what makes up those conditions in lower-income settings. So in high-income countries, that's mostly trauma, ischemic heart disease, respiratory failure, from pneumonia and stroke, but a lot more different types of infections and maternal and neonatal conditions in low-income countries. And then sort of along similar lines, we know that the burden of critically ill patients is similarly high or higher in low-income settings, but critically ill patients are more likely to die of their illnesses in low resource settings. The diagram here is showing that the odds of death in low and lower middle income countries is about twice as high as in high income countries once you adjust for illness severity, and that in low income countries, almost 80% of deaths would potentially benefit from the availability of critical care, which is often unavailable in those settings. And then the last thing, as we sort of round out talking about a little bit of background with all of this, is to mention the recent World Health Assembly resolution, again, emphasizing that emergency critical care and operative care represent a people-centered continuum, that integrated service delivery is required to link from primary care to in-hospital care with communication, transportation, referral systems. And really, this is not a single approach problem. This requires funding, governance, ensuring universal access, integrating service delivery, and then having safeguards in place for situations of disasters, fragile settings, and conflict-affected areas. A couple of diagrams just to emphasize that context-appropriate critical care is not always what we think about with ICUs in high-income countries, where patients are on a dozen drips and a ventilator, and renal replacement and ECMO and balloon pumps and lots of invasive therapies. This is a picture from the emergency department in the resuscitation area at St. Paul, where Dr. Mumbal works, where having an oxygen cylinder and monitors and a bedside chart where a nurse is providing intensive monitoring to identify clinical deteriorations and stabilization for those patients may be the cost-effective and clinically effective critical care that's necessary. But even just recognizing when somebody is desatting and needs more intensive oxygen therapy, or is becoming hypotensive and hypoperfused and needs resuscitation with fluids or vasoactives, can certainly be life-changing and life-saving. And so scoping the critical care interventions to what is feasible and effective for those patients is really the name of the game. So to do that, we need data. And as you guys know, in resource-limited settings, having accurate representative data can be really, really challenging. We know that what works best in high-income countries is not always what works in low and middle-income countries. A couple of examples, a paper from JAMA from a few years back showing that when you use kind of early goal-directed therapy for sepsis in Zambia, patients tend to get volume overloaded and have more respiratory failure and increased mortality with early aggressive volume expansion. Study showing that TXA has no impact on postpartum hemorrhage in higher resource settings, but does significantly reduce mortality in lower resource settings. And then a ICU QI project for Brazil showing that the sort of QI interventions that significantly affected outcomes in the US and Europe did not affect patient outcomes in a middle income country. So we can't just expect that we were going to be able to boilerplate translate what we do in America to other settings and have the same increased quality and same value of care. But many low and middle income countries have little or no published data about emergency medicine and critical care. This was a diagram from a recent systematic review of critical care services being provided in LMICs. And you can see all the countries that are blue here have no published reports or very few published reports at all about any sort of critical care service provided. This wasn't just limited to critical care in ICUs, but also critically ill patients in other settings. And in the reports that were published, much of the critical care was provided outside of ICUs and by non-intensivists. And there's very, very little data published about interventional studies or cost effectiveness of the care being provided. So we have a huge data gap. There are a couple of different ways to approach that data gap. Probably what's done most commonly still is retrospective data collection. This is often cross-sectional chart reviews where researchers or trainees will pull charts on, all of the patients presenting with spinal cord injury or with stroke or with pericardial effusion to an emergency department or to a hospital over a time period, and then do a retrospective analysis of this. it's easy to do that because it's using data that already exists. But I think that there's a lot of risk of missing charts, missing data, having things that were, not having all of the variables that you would like to have had collected, having trouble following patients through a course of illness. And so there's a lot of risk of inaccurate and biased data with that sort of an approach. Another option that we'll talk about some more is prospective data collection, where you collect what's needed to answer your research question. Obviously, this takes more time and resources to have data collectors who are working real time to follow patients through a course of illness, but can be a great way to answer individual questions about disease processes and clinical outcomes. We'll talk some more about clinical registries. With a registry, you have to balance between essential and comprehensive data collection. You want to try to record every variable that a patient generates through their illness, and risk missing the ones that are really important, or really just focus on catching the most important variables and understand that you're going to lose some granularity by focusing on the things that you think are most important to answer research questions. Registries can be a great way of evaluating trends over time, secular trends, looking at impact of interventions, and then benchmarking. So setting sort of local standards for comparison between similarly resourced settings and similar environments. So instead of comparing provision of care between Ethiopia and the US, maybe it makes more sense to be comparing provision of care between Ethiopia, Kenya, and Uganda, and figuring out within those similar sorts of settings what practices are most effective and most cost effective, and then replicating what works locally instead of trying to reinvent the wheel in each setting. And then lastly, I think hopefully the direction that we're working towards eventually is integrated hybrid medical records. And if you guys have experience with Epic and Slicer Dicer, being able to pull big data out of an electronic medical record and balancing between an electronic medical record that also can function as a clinical registry. That's a big data endeavor that is a challenge in high and lower resource settings, but as lower resource settings are moving towards more electronic medical records, I think offers another opportunity for more comprehensive data collection. All of that to say, whatever your approach to research and data collection is, garbage in, garbage out. If you're not collecting accurate, comprehensive data to answer a clinical question, then the answers that you're going to come up with are going to be misleading and ineffective. And so the challenge of collecting high quality data to really addressing clinical questions is always a challenge. And with that, I'm going to turn over to Dr. Mumbaugh to talk about a couple of cases of how these sorts of challenges have been addressed and tackled within the last few years. Mumbaugh, I'll go ahead. I think it's probably easiest if I advance slides for you. Are you able to share? Even better. Fantastic.
Thank you, Adam. I think I am able to share.
Yeah,
can you see? Good. Thank you very much. Thank you, Adam. It was a very wonderful presentation. It may not be easy for me to talk after you. Good morning, everyone. Here in Ethiopia, it is evening. Good evening also. So this is Mumbaugh Sultan from St. Paul's, Addis Ababa, Ethiopia. I am an EM physician and intensivist. For those of you who joined us now, welcome. So I am just going to present two cases where we have used our data for quality improvement and improvement of our care. So I will present two cases. One of the cases was published in Lancet. It was during the COVID time. I was one of the national lead in this paper. This was patient care and clinical outcome of patients with COVID-19. It was COVID-19 admitted to Africa. It was a multi-center retrospective observational cohort study. So, this is also called ACOS study. So the problem we had was patient outcome after critical ICU admission during COVID time were not sufficiently documented in Africa. So we were not aware of the outcome of critical ill patients in Africa. And we think our hypothesis was ICU admission and mortality will be high and the outcome will be poor because of a small workforce and low number of intensive care facility and the scarcity of critical care resources. So this was our hypothesis and we aimed to answer those questions. So we aim to answer what are the resources we have, clinical characteristics of our patients being admitted to our ICUs, critical care intervention we are doing, and factor associated with mortality. With this objective, so the method we use, it is multi-center, prospective observational cohort study of those patients admitted to ICU. We were able to incorporate almost 10 African countries. The PI was in South Africa. So Egypt, Ethiopia, Ghana, Kenya, Libya, Malawi, Mozambique, and some more 4 African countries were part of this study. And we were able to involve 64 ICUs in 10 countries. So in 64 hospitals. So we were trying to involve as much ICUs as possible. And the data collection was into 2020. So I think for almost 1 year, from May to December, and patient followed up till patient discharge from ICU or 30 days. The primary outcome of this study was in-hospital mortality, and the secondary outcome was factor for mortality. So data collection was, it was a very simple single sheet, easily documented sheet, and it was a tick box. So you can see the data sheet here, only one paper or kind of 2-page data collection sheet. It was very easy to collect this data. It has a tick box, and it also electronically can be filled. This was the data collection. The result we have seen, like demographically, the involved hospitals are mostly tertiary care hospitals. Tertiary care hospital, it causes some bias, of course. So mostly government hospitals were involved, and university affiliated hospitals. So we were able to understand the surge capacity, critical care oxygen capacity, and supply and pulse oximetry availability, so that we learn the capacity, the resource we have. So in addition to that, mortality was higher in low resource settings. We were able to understand the mortality was 53% higher. It was 48.2% in Africa. Of course, those patients who are died were not intubated, like 64% were not intubated, and 49% vasopressor. So only 64% were intubated, and the rest were not intubated, while they require possibly intubation. And we learned the association of the critical care mortality, like SOFA score, HIV, diabetes, and other causes of mortality. It's not the purpose of this presentation, of course, is not to know the detail, but the value of the large data sets. The strength was, it was a large and diverse multinational sample, and we were able to collect rapid data collection, high quality data, and it was pragmatic. When we get the result, always we were changing our practice and improve the situation of the critical care capacity. So it was pragmatic and minimal external funding. So the local government and the hospitals were interested and involved, but it has limitation. Some external validity. That means we were considering Africa as homogeneous, like the northern part of Africa, like Egypt and South Africa, or the southern part of Africa, much different than the eastern part. It was the resource, the patient demography, and also we were considering Africa as homogeneous. That was the limitation, and we didn't continue the data collection afterward. This data was disease specific. This was the limitation, but we were able to learn when we involve the leadership, it will be effective. So leadership involvement is very good to be effective, and benefit of multi-center involvement. And like we may not get adequate data in small unless you involve multi-center, and you will learn in multi-center involvement. Use of data for improvement and collaboration. The other registry we are using for quality improvement is the ICU registry. This is one of the papers that came out of the ICU registry. This ICU registry was part of the critical care Asia Africa registry, and almost more than 6 African countries are, more than that, African countries were involved. So this database and around 42 ICUs were involved in Asia, including India, Pakistan, Afghanistan. This is a big data. So the objective of one of the paper, part of the bigger objective of the database, were the problem we know is high mortality among critically ill patients in sub-Saharan Africa. So there are reports, individual hospital reports, where there is high mortality in ICUs, and we don't know the case mix, process of care, and clinical outcome in Africa. So we want to know the case mix to improve the care in Africa. So this database aimed to improve these things. The objective is almost the same. We are planning to identify priority targets for QI efforts, in addition to know the case mix and complication rate and ICU mortality in our hospitals. So these are the hospital and involved in Asia. So this is part of the Asia-Africa database. So the method for this paper, so we were collecting data in our ICUs. So retrospectively for 1 year, we want to know retrospective cohort study of ICU registry. Every day we are collecting data from our hospital. In Ethiopia only, almost 5 ICUs and 2 emergency critical care units are involved in this database. For this paper, we involved 2 hospitals, our St. Paul Hospital and Abbott Hospital, and we are able to involve 496 patients. We followed the patient until ICU discharge, and the primary outcome were ICU mortality, secondary outcome factor associated with mortality, and data collection. As I said, it's prospective data collection. We used tablets to collect data, and we have dedicated data collector, and we upload into the secure online platform, and we have also we are using it for monthly quality improvement in our ICU, and able to extract de-identified data from that database. This is the front page of the database. So we are collecting this data extensively. So it has a huge data. So result-wise, we are able to know most of the ICU, almost 50% of ICU admissions are mainly respiratory problem, head injury, and sepsis and septic shock. More than 50% of our patients are with this characteristic. So this helped us to know a case mix and to improve our care, and the complication is high. 41% of patients will develop the complication. So this is a big entry point for quality improvement. ICU mortality was also higher, 35.3, almost double than the high-income centers. And those patients with respiratory failure, sepsis, and vasopressor requirement have higher mortality as compared to the Western countries. So this database has a huge impact. The first one is there is a feasibility. We learned it. It's feasible to have ICU database in sub-Saharan Africa, and better understanding of local case mix, and it helped us as a foundation for QI effort. Now there are some QI projects going on through this database, including improvement of hospital-acquired complication. One, we are using quality improvement for ventilator-associated pneumonia, helped by Dr. Adam Laitin, one of co-presenter here. So the strength of this database is it was a large data set with longitudinal data collection. So still we are continuing collecting data, and when we are having with this large data set, even specific question like tracheostomy, other complication, we can collaborate with other centers to have adequate sample so that we can answer our questions, and research output, answering clinical question and addressing QI needs. And we piloted this for other region and regional hospital and international research, and concurrent and evaluation of implementation process. So it provides for database, a baseline database. There are challenges in this database. Sometimes we will not get accurate data. Sometimes it was not feasible. When you check in other data for VAP, there are missing data or unreliable data also. In this case, Apache, when you compare it to the Western Center, feasibility is very low. So still there are challenges in the quality of data. And when you want to modify this data set for a specific question, it is difficult. You need IT person and the agreement of other centers. So it's not easy to modify the database. Data usage for quality QI and surveillance is not easy. Always we need expert and interest from hospital. Balancing local and foreign experts and leadership. So there are interests, the local interest and the international interests. That also has some limitation. sustainability issue. Now we are being funded by external fund like Critical Care Asia Africa Database Group and the Oxford University. So we are communicating with the Ministry of Health to expand it to the national level and have sustainable funding for this database and expanding to the emergency department also. So we are being funded by external grants. So we are planning to expand it to the national level. So lesson we learn, and we need to have standardized ICU and ED collection data. So we can't use the Western database to local center. Always we have to modify and have a standard ICU and ED data collection tool in low resource settings. And we need to improve the data set always. Accurate clinical data are the foundation of QI development. So we are having difficulty in QI development when we are having less quality data. So accurate data and quality data are very important, essential to improve institutional and national leadership and opportunity for data sharing. So we are sharing data, like people were asking us for, they are having a limitation in data like fluid responsiveness or dengue fever, something like that. So we are sharing our data to the international colleagues and have a good answer to our question. And leadership involvement is very important. So we have involved our hospital leadership, also involved the national leadership. They are okay on the database, but still there are limitations in funding this database. So still we are involving the government. Thank you very much. Of course, it is a brief. I will hand over to Dr. Adam Laitin for the other presentation. Thank you very much.
Thanks, Mambo, and thanks for going through those two examples in such a thorough and thoughtful way. I hope that for you guys in the audience that this gives you a little bit of a flavor of how this isn't a one-size-fits-all approach. Really, we need to think about what sorts of questions we're trying to answer, what sorts of research resources we have available, and then to right-size fit the research strategy to the clinical questions and the resources. I think ACOS was really astounding in being able to collect a tremendous amount of data from a number of resource-limited settings really early in the pandemic when I think a lot of us were just struggling to keep up with the clinical load, and to get that data out that really helped to shape how we think about COVID care provision in sub-Saharan Africa. And then the critical care Africa and Asia registry that we've been working to adapt and implement in Ethiopia is a much more sustainable long-term data collection strategy that's really useful for identifying and then evaluating QI targets, like Dr. Mumba mentioned, using illness severity scores like Apache to quantify not just what the overall mortality is, but are those patients dying because they're really sick patients or because they're not getting the care that they need, and how can we improve risk-adjusted outcomes by through quality improvement and capacity building efforts. I think when, I've also been involved in a couple of other registry projects. There's been a lot of excitement around trauma registries and other sorts of ED-based registries as a way of collecting data. I think when we're going to implement clinical registries, especially in low resource settings, there are a few important considerations to have in mind. One is that you need to really be thoughtful about what the quality indicators that you're using are. This includes the structure indicators. So like you guys saw with ACOS, how many hospitals actually have pulse oximetry? How many actually have working ventilators? How many actually have the capacity for renal replacement therapy? The process indicators, like how many patients are actually being intubated or receiving vasopressor support, and then the outcome indicators like overall mortality. It's really helpful to have a standardized approach to data collection and curation to ensure that you're getting high quality data. And so you saw with ACOS, it was that single sheet where it was mostly just numbers and check boxes to really standardize how data were being collected and make sure that it was going to be comparable across different sites, and not that everything was being written freehand, and then you have a nightmare of trying to standardize and clean that data on the back end. ACOS, the data could either be directly uploaded to the database, or they could actually mail in those patient sheets tear off the patient name from the bottom and then have a de-identified patient sheet that can be mailed in and collected. It's been a different approach with the Critical Care Africa and Asia Registry, where a lot of that data collection is through a tablet app that mostly uses drop downs and numbers to provide standardized data collection, and that gets uploaded to the cloud in real time, so you don't need to worry about computers crashing or patients being lost. Having a way to account for differences in illness severity, like we talked about using Apache to calculate a standardized mortality ratio, that's your observed over expected mortality, is really important for benchmarking performances. One thing that we found with the Critical Care Africa and Asia Registry is that one of the key components of Apache 2 is blood gas, the pH and the PaO2. And in Ethiopia, blood gas analyzers are usually unavailable because of the inavailability of reagents. And so we can't expect that the Apache score that you're going to calculate in Ethiopia is going to compare to the Apache score that you're going to calculate in the US, but it probably will compare between different hospitals within Ethiopia or between Ethiopia and other countries in sub-Saharan Africa. And having some way to standardize, is a hospital with higher mortality actually providing a different quality of care? They just have a different case mix is really important for quality improvement. Just collecting the data is not sufficient. You need to feed back that data for hands-on quality improvement efforts. And Dr. Mumbo mentioned the ventilator-associated prevention work that we're working on now using the SQ registry to track changes in outcomes with QI efforts. And QI isn't just about saying, okay, this is something that now we know that VAP is a problem. To change outcomes, you need to change behaviors. Registries need to be able to evolve to meet dynamic needs. And then this was actually a cute little diagram that was published in a commentary to that paper that we published in the Journal of Critical Care. It was sort of talking about the iceberg of clinical research in using clinical registries. And so the above the water part that we think about now is the sort of the pyramid of evidence with expert opinion, case control, and cohort studies, RCTs, and then up to the apex of systematic reviews. But moving forward into the age of deep learning and AI and precision medicine, there's a whole space of research that will be able to mine these clinical registries and hybrid electronic medical records to pull out data that we aren't usually collecting with RCTs or retrospective descriptive studies. So clinical registries can enable things like ecologic and cohort studies of patient populations. They can generate large data sets for predictive modeling and data science initiatives, and they can gather long-term outcomes data and connect with other data sources and other disease-specific registries and enable embedded clinical trials. A couple of sort of last thoughts here. These are the WHO building blocks of system strengthening. We've done a lot of talking about the information block here, but as we had sort of touched on earlier, this is never just an issue of generating more information. If we want to change overall outcomes, then we need to think about how this is going to impact service delivery, workforce development, availability of medical products and technologies, financing, leadership, and governance. And all of those are pieces together that better quality of data can certainly help to drive that process, but just the data alone is not going to solve the quality gap in low resource settings. A big sort of underdeveloped piece of this that I think is really important moving forward and thinking about what we do with these sorts of data is thinking about implementation science in global health and health systems development. So this is the study of methods to promote systematic uptake of research findings and other evidence-based practices. And so another way of saying that is really focusing on bridging the research to practice gap. So we've spent a lot of time talking about the research gap, but then turning those findings into improved quality is where implementation science comes in. This can't just be following international guidelines and overlooking local data. It's not always clear what the priorities should be from a bird's eye view. And so it's really important to respect and empower community stakeholders to make sure that we're not just saying, okay, we in the US think that the priorities for system strengthening in another country should be A, B, and C, but that we really engage our local partners in those settings to develop a QI and system strengthening agenda. I think, summarizing here, challenges in doing this sort of work, making sure you have high quality data collection, that you're collecting data in a sustainable way, that when a specific grant runs out, the projects don't fizzle and collapse, but this is really a sustainable effort to build and change health systems. We talked a little bit about needs for accurate methods of risk stratification, context appropriate illness and injury severity scores, ensuring that we aren't just collecting data, but we're actually using that data to change policy and practice, that we're aligning agendas between researchers, hospitals, administrators, clinicians, and local governance and ministries of health. And then evaluating implementation processes to make sure that research and QI efforts have been optimized for local settings. And so addressing all of those, there are frameworks for doing this within implementation science research. This is a whole other talk that's sort of beyond the scope of what we have time for today, but hopefully this will stimulate a little bit of excitement for implementation science for you guys thinking about how you're going about research and systems building in resource limited settings. So I think we'll stop there and have a couple of minutes for questions and discussion. If nothing else, I want you guys to remember, if you can't measure it, you can't manage it. There's no single right approach to clinical research and clinical registries and QI in resource limited settings. And it's really important to fit your data collection and research strategy to the questions you're trying to answer and the resources you have available. I will stop there. I hope that this has been interesting and informative for you guys. I really, again, want to thank Dr. Mumble for joining me with this, because I think his perspectives and experiences in these projects are really invaluable. And I also really would emphasize, you guys, that when you think about presenting your own work in the future, that you think a little bit about the equity of healthcare research in resource limited settings, and engage your collaborators and make sure that this isn't just a bunch of Americans sitting around talking about global health research, but is a bidirectional exchange where we're valuing the voices of our incredibly accomplished and incredibly talented colleagues in other settings, and giving them the chance to share their accomplishments also. So I will stop there. Questions? Any thoughts from you guys?